So what I'd like to share with you today is, in my role at IQVIA, what I see as being done on a routine basis. We're not in the academic research environment on the frontier of, or even in pharma companies in the frontier of thinking about what's next, but we do see what customers are treating as more routine. So I'd like to identify a few things that are becoming routine and some implications from that, and a few things that are not yet, which I think entirely aligns with this IFORD agenda. So here's life. I think it's generally accepted, even for physicists, that it starts with birth, and then we're all in the waiting room, and at some point you get a diagnosis. Hopefully, at some point you get therapy, and at some point you get outcomes. So, if that's life, what do we know about it? So the data on life tends to be an annulus like this. It tends to, it exists, and we were just discussing. By the way, can you all hear me okay?
Yep.
Okay, so data on life kind of exists in its highest density, post-diagnosis, during therapy, and looking at outcomes. There's stuff that happens before, but like we said, for the kind of things you're looking at here, like diagnostics for prognosis for rare disease onset, pre a formal diagnosis of something that's probably quite complicated and multidisciplinary, there's not a lot that happens. But data on life tends to hit in that kind of a period there. And by the way, I'd love questions and interruptions and corrections along the way. So just jump in as soon as you think something's off or not quite right. But I think that's when most medical information kind of occurs, at least from what I've seen. So then what happens when you try and use that data on life to do stuff? Well, that data on life that we have as IQVIA, and plenty of other people have too, is, we have the EMR records because we buy them from multiple hospital systems, and it's ICD-10 codes, and it's mostly for the purpose of billing. It's not really as acutely tuned to clinical diagnosis as it could be. And we have Cerner and Epic to blame for that. And at some point, they'll be taken up to The Hague for crimes against humanity. And these are my views, not IQVIA's. But there's EMR data. And you've got clinical trial data, pristine data, highly qualified, highly dimensionalized. However, limited. You don't run that many clinical trials. We run about 1,000. In any one day, we're running 1,000 trials. And we're about 13% of the market, so you can do the calculation, but still, it's a small fraction of care when we know that. We run, and everybody else runs, patient councils, which are turning out, I believe, to be extraordinarily important, because whether you're UCB, whether you're Roche, whether you're Pfizer, we tend, from the science and clinic perspective, not to understand how the patient got to us. And we tend not to understand how to meet them where they were earlier. But those patient councils and the patient journey work, I think, are becoming an increasing focus on pharma, and we support that. We support the conduct of doing those things, and that's really important information. Claims information, like who pays for what, registries. We talked a little bit about how patient foundations are at the intersection of having a white hat of being trusted and sufficient funding to actually move beyond the very important aspects of advocacy and education to actually getting into doing research. So I'll speak to a couple of registries or patient foundations that are running registries, which are actually phenotypical, genotypical hybrids that allow direct from patient intelligence as the disease progresses, and then scripts. We know who writes what scripts. In the US, like 94% of all scripts we can track, and these are all, as you will note, towards like the end stage of a disease progression, but still some of these combination of disease progression and data assets, they are affecting meaningful identification of rare disease patients. So I wanted to talk to three things. One is just as you begin to get into clinical trials, there's some ideas on creating platforms which will harmonize and streamline data, particularly in gene therapies for rare diseases, for ultra rare diseases. And to give you an example of that, I think that's a trend which is important and could benefit initiatives like this, and certainly we need to keep an eye on. The second one would be diagnoses, and so that's almost sort of post outcomes, taking outcomes data and seeing what you can learn to regress back to find the next series of patients you may have missed. And then the third one is around community, which begins to get back into this pre-diagnosis, general population surveillance side of things. So those are the three topics I'd like to just touch upon, and these are just observations about what's happening. It's not that we're driving them, it's just what we see people driving and we're helping support. So if that all makes sense, moving to one in this schema, the one closest to the clinical trial side of things, and this comes partly from the Foundation for the NIH, partly from some stuff that we and others have done, but it's been spoken to before. Like, the investment in the ROI ain't there in general for rare diseases, and so you need to find something that's more bespoke. And the NIH has created this initiative called the Bespoke Initiative, which I'll speak to in a second, but it's to reduce the barriers to more folks getting in the pipeline with gene therapies, particularly AAV gene therapies in rare diseases. And the analysis is, so why aren't more people prosecuting agents in this area? And on the right-hand side, it's confusing and it's changing all the time. The regulatory pathway has to be adhered to. It's rule one, and yet it's really complicated and hard to navigate. And then there's GMP questions, there's finding sites, there's people, there's manufacturing capacity, all of those kinds of things. But item one is the rule book isn't clear at all. So I'll pause there and see whether that resonates with people, whether this is already feels misguided, or whether people are tracking this. Julie, does this make sense to you?
Yeah.
Still there, Julie?
Yeah. Can you hear me?
Yes, I can.
Yeah. Thank you. Yeah, thank you so much for the nice presentation. I fully agree with that. I think, at the moment we have seen quite a lot of interest with the data platform. It's still a bit, unclear on how we can, how we could differentiate with the disease-specific registries, but I think the fact that those data platforms will better leverage the existing data instead of creating a new initiative that is about collecting new data with all the implications in terms of cost and timelines is definitely a better strategy, I would say, to generate evidence quite fast. So yeah, I've seen the concept evolving over time and now being deployed across different therapeutic areas.
Okay, great. All right, I just wanted to check with the experts that this all still makes sense. That's good. And so, bottom line here is that the understanding was that if the community that would like to solve for this, and its patient foundations, and its academics, and its biotech, and later it'll be big pharma, but if they can have a streamlined pathway, particularly for well-known tech like AAV, it would help. And so what we've been working with the NIH and FNIH and FDA on, and we're still working on, is getting to that high point in the peak of you can do a study by streamlining the pathway through Interact, pre-IND, and IND meetings, because it's confusing. So the really cool thing is there is now a facility, an information facility, which helps guide the optimal pathway to, you can do a study, you can do a phase 1, and NIH is the IND holder for those 8 ultra rare diseases on the left hand side of the slide. So I think we've spoken about some of those previously, but those 8 are going to get under NIH funding through preclinical gap closure, and there'll be an attrition, I guess, at some point, but into a phase 1 study, and then into necessarily a long-term follow-up for those patients, because that's a regulatory obligation. So this is extraordinary, I think. NIH is pushing these through to patients, with the FDA being on board. And we've been helping write that playbook, and we'll help manage this portfolio of 8 as they move through the process. So, does anyone on the call have a particular interest in any of these diseases that we should follow up on?
Maybe we keep the question for the end, Adrian. Okay.
Okay. All right. So that's a platform thing, and the way it works is you can cross-reference master data files for various quality criteria and assays and manufacturing parameters. So if you adopt the same manufacturing process to get to the outcome, you don't have to redo the work, which is a massive streamline. And so this product, this accelerator, hopefully for getting more ultra rare disease guidance and support for development programs, it's at that sort of second step now, where it's just going to be used on those 8 indications on the left-hand side of that slide, and then after it's been developed and any efficiencies have been properly evaluated, become more broadly available to biotech and pharma. But right now it's just this NIH. Let's test it and see what's happening. So that's a platforming of the approach to create a therapeutic sponsored by the NIH. The second part of things is really on the looking at outcomes and what can you do with them side of things. And again, these are not one-offs; they're established trends, and you got to anticipate that every therapeutic developer is going to be leveraging them going forward. And it is an example. It's Bubble Boy, and this is an example of what we kind of do routinely for the industry. But it's interesting because it touches on some of the techniques that are being envisaged by IFORD. You take the whole series, you take whatever data you can, with every healthcare interaction you can, about a diagnosed population, and then you run it through it's more ML than AI, but people tend to blend them. But you run it through a machine learning pattern recognition approach in order to identify undiagnosed patients. And undiagnosed patients in this case, was what's called leaky ADA SCID, and it's folks that have a partial representation of the symptomology, but not a full representation. But still, it's enough to identify them as precursor SCID. And in that case, it's and again, I've used ML in my physics days, but I'm not the expert in life sciences and healthcare. You guys are, but this. My point is, this approach is now becoming kind of routine in biopharma, and we're doing a lot of this work. And I wouldn't say it's retail, but it's or commodity. It's certainly the smarter companies that are doing it, or the better funded companies that are doing it. But finding the next series of patients for ultra rare diseases or not well-defined precursor diseases is becoming kind of standard practice for biopharma companies now. And that's the message, that this may have been new at some point, but now it's becoming more a service that people provide. That was number 2 in our schema about what you can do as you get towards the periphery of that annulus on diagnosis. I think closest to the not exactly, but closest to what IFORD is intends to do is an organization called the Follicular Lymphoma Foundation. So back to foundations. So Nicola Mendelsohn, on the left-hand side, is publicly a patient diagnosed with follicular lymphoma and wants to generate a combination of direct from patient information, and the mechanisms to do that are not yet entirely clear, so it might be an opportunity to help, plus molecular data. So we've got to decide upon, maybe it's the Victor stuff, you've got to decide upon exactly what assays and at what cost, but it's different disease by disease, but for follicular lymphoma, what does it look like? Plus ongoing EMR integration, plus some kind of customized analytics and reporting that can sit on top of data so that it can be monetized for sustainability processes. It's a not-for-profit, but sustainability processes in order to give a return to the foundation. So one of the things I find fascinating, and full disclosure, I'm on the advisory board for Follicular Lymphoma Foundation, and both my parents died from non-Hodgkin's lymphoma, of which this is an indolent form. Nicola's, I'm sure she wouldn't, feel uncomfortable me saying this. She's one of the top 5 people in Facebook, and she's already got a materially large, for relatively rare disease, Facebook community. And I know that IFORD's about early detection of things before diagnosis, but with an indolent disease, it's not just diagnosis, it's about propensity for progression. Because you can go for 20 years with FLF and be fine, but then at some point it kicks in and you got to seek treatment. And so I think it still falls into the kind of surveillance and the radar scheme that many people have been talking about. So I think this is a new trend. I've seen it in several areas: muscular dystrophy, multiple myeloma, where the patient foundations are moving beyond good and necessary roles of advocacy and education into actually collecting a hybrid of phenotypical and genotypical data on their populations and doing some predictive analytics on them. So the whole idea that there's a connection to Facebook here is fascinating to me. We're at the very early stages of understanding if and how that's appropriate to leverage. But there is a Facebook population, and we nicknamed this project From Social to Sequence, because we want to take them out of the the Facebook world and into the scientific world. So that's another trend that's happening. And if it were one foundation, you'd think, yeah, that's kind of interesting and quirky. But if you put in cystic fibrosis, multiple myeloma, juvenile diabetes, it's probably 6 or 7, and then it becomes a trend, and it becomes a movement. So I think that's another important thing to think about and harness, just from a supplier perspective and seeing what's happening in the market. The last couple of things I wanted to touch upon is, why are these ideas becoming more relevant, practical, prevalent now? And of course, it's 21st Century Cures Act, where, there's lots of words on this slide, but bottom line is, your record in the US, your record is your record, and Epic and Cerner are encouraged to facilitate interoperability, and you can move it wherever you want to at your call. And there's a place for it to go because of interoperability and HL7 and FHIR. So we're doing more and more work for entities, whether it's pharma companies or foundations or government, to do that large-scale aggregation of EMR data that really hasn't been possible for the last sort of 18 months or so. So that's a big enabler that any large-scale surveillance, even though you want to go pre-diagnosis, there's something in the EMR pre-diagnosis, and it might not be nuanced or precise enough for a differential diagnosis, but you can now get it now in a way that you never did before, and you can automate it through FHIR. So I think that's a big enabler for the kinds of things that this group wants to do. And well, left-hand side, right-hand slide, the words don't matter, but you can see that it means that there's a universal, there's a Catholic approach to the harmonization and aggregation of this data, which simply didn't exist 3 years ago, but exists right now. And anyone that's going to succeed in this business has to have a play there, or a way to access those kinds of technologies, because the left-hand side was always impractical. That's why we never saw large-scale aggregate data on any disease. The right-hand side is today, and that's a big change. So that's a trend. One more trend is what you guys are thinking about doing, as far as I understand it, and I'm a newbie, I know that, but it requires access to a large population. But 3 things. Thing number 1, access to a large population, what you call community, or general population. Thing number 2, a degree of intimacy. People are going to have to share how they feel, or what meds they're on, or what they posted about their mood or tremor or gait or whatever. So there's a high degree of intimacy there. And the third thing is, it can't be a one-off. It can't be a single instrumental survey, gets returned, and that's the end of the relationship. It has to be some continual give back of value in order for the profile to be longitudinal over decades, or at least over the life cycle of the disease. And there was actually a project funded by Robert Croft, who is an East Coast billionaire. He owns New England Patriots. He's got more money than God, and he gave Harvard Business School, again, not a shoddy brand, not a bad place to develop ideas, some money to think about, because his wife Myra died of ovarian cancer, and he believed that there could have been more done if there was more sharing of insights across cancers. And he thought that business probably knew a bit more about how to engage people to provide that information. And so, you had in these series of meetings, which are all codified at that link underneath, and it's worth a browse. Even if you don't like it, it's worth a quick look. But they, so we had meetings where at the business school where we had Chief Marketing Officer of Peloton talking to the CEO of Intermountain. The Chief Customer Engagement person at Marriott talking to another disease. So it was this real mingling of, because that's what Marriott does. That's what Peloton does. Have a large number of people. They gather information from them, which is kind of personal, not as personal as medical, but kind of personal, and they maintain that relationship for decades. So this is all about how to engage, and it's a business prospect. And I think we can't be blinkered to business models. And there are some interesting business models that are highlighted here at that link. Finally, it's a donut. We've got all the stuff on the periphery that happens, peri-diagnosis and treatment and outcomes. And you guys are the experts, but there's this gap in the middle that needs some jam in order to fill out the donut. So with that visual, and thank you to my son Finbar for creating it. It is machine shot last night. I'll open this for questions.